A very good afternoon to everyone present here. I know post-lunch sessions are traditionally having a debate themselves with our metabolism and our attention span. So let's try to keep it clinically relevant and hopefully mildly entertaining to all of you. And since all of you have been listening to our great speakers from morning, I don't really think I have to work too hard to prove my point here. And we'll see how my friend, my dear friend, puts up a brave front and fights for antibody testing. So I'm going to be arguing against indiscriminate antibody testing. I'm a rheumatologist. Please remember that. So I love antibodies and antibody tests, but I am against indiscriminate testing of antibodies. That is when the problem really starts. And antibodies can be excellent helpers, but are very bad bosses. So let's start with what we all know. I think what has been repeatedly told to us throughout this day has been that ANA positivity is common, and in the general population we see somewhere between up to sometimes 20 to 25% of ANA positivity. Depending on the course or the paper that you would like to quote, you can get a variable percentage. Only a very small fraction of these ANA positive patients do turn out to be or develop a connective tissue disease. So a positive antibody test statistically means that it will belong to a healthy individual rather than my next lupus patient. So this point alone should make us want to stop before we order for a test. Now let's move to rheumatoid factor. Rheumatoid factor is having a major commitment issue. It's always in a situationship, like how the Gen Z says it, and never in a committed relationship with anybody, especially not rheumatoid arthritis, because rheumatoid factor can be seen with increasing age, in infections, and many other conditions. Also, I think we need to focus on the fact that 30 to 50% of our patients can be seronegative and still have clinical inflammatory arthritis. So what really is the problem? The problem is not the test. The problem is what really follows after that. The result of a positive test is further testing, okay, and referrals, which is unnecessary sometimes, a lot of anxiety in the patients. Sometimes Google searches at 2 a.m. in the morning to check whether I am having lupus. And sometimes this even leads to unnecessary treatment. And this is when it stops being benign. Over-testing leads to over-diagnosis, and over-diagnosis leads to real harm. Now let's come to why this debate is important. Because let me mention that joint pains and skin rashes, as you all know, are one of the most common symptoms that we would see in clinical practice. Antibodies are not always disease specific. So what happens when you combine a common symptom with a non-specific test? Obviously, false positives are abundant. So over-testing, like we said, leads to over-diagnosis and also causes a lot of unnecessary anxiety among patients and a lot of unnecessary confusion among us clinicians. Now, I'm going to take you through a few case scenarios to help me prove my argument here. So first case is the 2-week RA. It's about a 50-year-old male who presented with history of 2 weeks of vague joint pains and muscle pains. He went to a doctor and has been prescribed a set of tests in which rheumatoid factor was present, and the rheumatoid factor unfortunately came positive at 53. So he was immediately labeled as rheumatoid arthritis and was advised to meet a rheumatologist. So he came to me, and when I went through his reports, his vitamin D levels were low, and also another detail that came positive was his hepatitis B was positive. So when I told him that your hepatitis B seems positive and that seems likely to be the reason for his rheumatoid factor, he said, no, I'm having hepatitis B infection since a long time, and I Googled, and it says that rheumatoid arthritis and it can be cancerous, and there's a lot of information that he got from the net, which caused a lot of anxiety to him. So what are we learning out of this case? The fact that every rheumatoid factor does not mean it is rheumatoid arthritis. And I think that has been mentioned today repeatedly about how non-specific rheumatoid factor can be sometimes. Rheumatoid factor, as we all know, I think by now, is that it can be commonly seen with chronic infections, especially hepatitis B and C, endocarditis, tuberculosis, elderly adults, smokers, and sometimes just because it felt like being positive on the day you tested for it. The second case here is the executive health checkup champion. And I think from the way it went today morning, we see a lot of health checkup being done randomly by patients because it is available. Now this was a 37-year-old healthy male who is very conscious and so wanted to make sure that he was healthy and decided to do an annual health checkup. His mother has rheumatoid arthritis. He, however, does not have any symptom. So he does an annual package, an arthritis panel, which showed a rheumatoid factor which was 117. He visited a doctor. The doctor asked him to wait. So religiously, the next year he did again the annual health checkup, which had the arthritis panel. And his rheumatoid factor was 198 this time, and he panicked. He went to the next doctor, and the doctor said that this is very high. So he immediately asked for a retest of rheumatoid factor, which showed a value of 117. So what does this mean? But he has been healthy all through this time. So this is our biology screaming at us and telling us that numbers can move even when there is no disease. So please remember this. Clinical lesson here is antibody positivity is not equal to disease, and testing an asymptomatic patient will create false diagnosis, will create a situation where we have to unnecessarily label somebody who is not having a disease and sometimes even treat them for something which treatment is not really necessary. And most of the times in such patients, the only thing we need to do is reassure our patient. But remember, as clinicians, once you have a positive test, the reassurance becomes very difficult for us to convince. Sometimes with a little more gray hair, it's easier, I guess, but for us, I feel we find it difficult to convince our patients. So the third case is post-infection antibody festival. I'm sure all of us have seen this too, where we had a 38-year-old female. She had 2 episodes of chest infection, lower respiratory infections, in a span of 4 months. She was admitted twice. The second time, BAL was done and culture showed growth and was treated with suitable antibiotic, and the infection cleared. However, because of the recurrent episodes, an antibody test was done for her, and the ANA profile looked as colorful as a multidisciplinary team meeting. Because the Rho was positive, the La was positive, the RNP-SM was positive, PMSCL was positive, everything was positive. So she did not have any features of CTD. If we have to label her, then she would be Sjogren's, MCTD, and even scleroderma. But that's not what we are looking at over here. So what do we learn from this case? The fact that autoantibodies become positive in infections, malignancy, age, and there can be a variability with the lab. I think ma'am has already emphasized on that. So the clinical context, clinical scenario is of prime importance. That should be the one which drives our diagnosis, and it should not be an antibody menu which is telling us what really the disease is. Case 4. This is of a 24-year-old girl who came with a very typical fusiform joint swelling involving the PIP joints, which was of a very short duration, about 2 to 3 weeks. And she gave history of a cough which was there since 5 to 6 weeks, along with the history. So she has already shown elsewhere, and this was diagnosed as rheumatoid arthritis because her rheumatoid factor was 68 as a part of her entire checkup, and was started on the drug tofacitinib. I'm sure all of you have heard of the drug because it's being used extensively without any proper checks that need to be done prior to starting the drug. However, after coming to us, while she was on tofa, her condition deteriorated rapidly over a period of 1 week, and she had severe breathlessness for which she needed admission, even a thoracoscopy, and that showed that finally she had tuberculosis. So, what really happened? The rheumatoid factor here was not rheumatoid arthritis. It was a mimicry by tuberculosis. So we have to understand that this antibody test, it resulted in unnecessary immunosuppression for this patient. If it was not caught early, then it would have been a catastrophic problem for us to handle. Next, moving on to the 5th and my last case, is when antibodies tell you a wrong story. So I think today morning there has been extensive talks about where certain antibodies can be positive, how specific and sensitive they are to diseases. This is just a 18-year-old female who presented with history of severe fatigue, 10 kg weight loss, low-grade fevers, facial puffiness, edema, a very typical history that you hear and you know it's probably lupus. And everybody thinks in terms of lupus. But her antibody profile showed a Rho-La positivity. Here is where the confusion comes. Normally, it's thought that Rho and La positivity is associated with Sjogren's disease. So, is this Sjogren's disease or is this lupus? Just because the antibody is saying something, does it mean that we are going to drive our diagnosis and treatment according to that antibody panel? So, here she doesn't have any Zika symptoms at all. So, we have to understand that isolated antibody testing and going only by that, it leads to a delay in diagnosis of diseases like SLE. We may miss certain organ involvement. We may even miss malignancy and lymphoma. And also something very important that we need to understand is it sometimes even gives a false reassurance, which means we don't see any specific lupus antibody. So maybe this is not lupus, but that's not the case. That doesn't mean that we should not treat this patient. So everywhere, it is always better to assess organ involvement, see the clinical pattern, and then do a targeted antibody testing based on the clinical case. And this is how we should practice. So what have my cases demonstrated? False positives are common. Infections can mimic autoimmune diseases beautifully. Serology without context causes harm. Autoantibodies are non-specific. And patients as well as clinicians, let me be clear, suffer when results are overinterpreted. Antibody tests do not diagnose diseases. It's we clinicians who do. And please remember, the antibody test is not there to take responsibility for when the test comes wrongly positive. We are the ones who have to answer. So let's be more mindful about what we are asking for. I think my friend will talk about when should you order antibody test. I won't be talking about that. Let's talk about when we should not order antibody tests. So non-inflammatory aches and pains, viral illnesses, fibromyalgia, initial evaluation of simple osteoarthritis, pop-up symptoms which has lasted for a very short duration, 1 to 2 weeks, unless it's very typical and classical features are seen, which you can see on the side where you should test, and executive health checkups. Please do not do arthritis profiles. It's a humble request. And also, please do not ask for antibody panels just because you thought so and you wanted to rule out something, because that's not going to give you any help. Let's look at the classification criteria. So antibodies are always considered to be a supporting actor, not the real hero. The real hero is always going to be your clinical examination. So ACR, ULR criteria are scored and they have joint pains, duration, morning stiffness, inflammatory markers and antibodies. They are not mandatory. We have something called as seronegative disease. So the clinical features can independently meet the diagnostic criteria. Remember this. For CTD diagnosis, pattern recognition is of more importance, and isolated antibody positivity in asymptomatic patients should not drive a diagnosis. So what happens when we overtest? There's misdiagnosis, there is wrong treatment, there is unnecessary expenses without any outcomes, unnecessary treatment which can be sometimes fatal, and of course, a lot of stress and anxiety. So we must move beyond reflexic testing. I think this is what I have said till now. Clinical wisdom, my take-home message. Clinical wisdom precedes laboratory testing. Autoantibodies confirm, they do not diagnose. Recognize the clinical pattern first. Order targeted tests. Interpret with context. Not all joint pain and rashes need antibodies. Evidence-based medicine means knowing when not to, than why. So at this point, I will just like to say a rule of thumb. I think Dr. Ashish also mentioned the same thing in the morning. If your clinical history is not giving you a clue and your examination is quiet, then ordering an autoantibody test is not going to give you any answers. It's just going to be a loud test which is not directing you in any direction. So I think we need to relook at what we are. Still, the clinical picture has to be the first one speaking to you. The antibodies can always enter the discussion later. Okay, and I think with this I would like to rest my argument. And I would like to invite my friend Prakriti to convince you otherwise. I think for till now I have done a fairly good job, and the previous speakers have helped me quite a bit. So yes, and she can probably order a few antibodies on the way.